Let me put you on game to a different way of thinking. Black King, empower the youth to live the truth, got big dreams. Black King, all of my brothers that are for each other, that's how we know we. Black King, bringing more unity to community, yeah. Black King.
Yes, you know what time it is, my royal family. My name is Walter Watts, and welcome back to King's Hour. Like always, I have my kings with me. Moog, talk to me.
We are in here, baby. Let's get at it.
That's right. JoJo, where you at?
What's good? What's good?
Now listen, for our listeners, this is part 2. And if you have not listened to part 1, I need you to pause, stop, halt, and go listen to part 1 because we do not want to lose you. You may have lost a couple of jewels there. So make sure you listen to that. And you can listen to King's Hour on any podcast platform. And you can also listen to us on YouTube. Just make sure that you search King's Hour so you don't forget to look at our pretty face as well. But for our listeners that listened to part 1, welcome back. And you already know our special guest from Utah. We have Daren. How are you doing, Daren?
I'm doing well. Thank you very much.
Hey,
pleasure to be back.
We're glad to have you back. And Dr. Baiden, how are you doing?
I'm good. What's good, everybody? Welcome back.
Oh, yes. Another day in paradise. That's right. And like I said, we change it up all the time. And here on part 2 of King's Hour, Black men with mental health, we have another special guest, another doctor, Dr. Ferguson. Please introduce yourself and where you are from.
Hi, everyone. I'm Dr. Richard Ferguson. I hail from Washington, D.C., not too far from RFK Stadium, where I was born and raised. And I came out actually to Utah when exiting the Army. I was active duty Army battalion and brigade surgeon for about 7 years. Finished in family medicine in the same program as Dr. Baiden. She was my senior. And I left that and have been practicing locums emergency medicine for, I'd have to say about 10 years now. And I'm also the chief medical officer for a small Medicaid, Medicare health plan here. And and also the president and founder of Black Physicians of Utah, trying to address health disparities through educating the community and increasing representation of Black doctors in the state.
Wow. That's beautiful. Let's make sure that we connect on that at the end of the episode so we can make sure our listeners are following you and make sure they get all the insight or events that you have coming up. So again, we are glad to have you guys here for part 2 of Black men and their mental health. And on our last episode, we talked about a lot that we had to make it a part 2. But really, the most important takeaway from everything was really creating a dialogue and making sure that we are comfortable as Black men expressing our feelings to one another or family.
Right. Hey, can I interject real quick? Because as I reflect a lot on the last episode, and I've been really just trying to dive into how to figure out creating action around, some of my thoughts and whatnot in there, where I kept finding myself in a roadblock, and I'm going to try to articulate this the right way, but I have a problem of being vulnerable, especially when I have a lot of examples throughout my life of when that vulnerability is held against me, especially as a Black man, thinking about all the things that have been thrown at us. I mean, even the N-word itself, we've been taught subdue. So, I was trying to think, okay, let's get up, let's figure out, what does that look like? What does the peace look like? What does vulnerability look like? But I always run into, but you don't want to do that because remember the last time you were vulnerable and maybe it didn't happen at the moment, but somebody used that vulnerability against you later on in life. So my question to the professionals here is, what do you do? I mean, is there a set process that you got with people to open them up? I mean, is it different with everybody? Just how do you create that dialogue and that vulnerability to get people talking?
Do you want me to go first, Eric, or you want to go? Oh, so one thing about that Eric and I have to do often, sometimes due to the pressures of just the American healthcare system, is you have to try and engender trust and a rapport rather quickly. kind of helps with our status because people are coming to see you and they're at least saying, all right, well, this person's gone through training, so I hope they know what they're doing. So we at least got that when they walk into the door. But so what I try to do is if I suspect that, because most mental health concerns that present to me, is say if they're chronic in nature or maybe acute on chronic, they're presenting with often a somatic presentation. They're coming in with a chronic headache. They're coming in with like this back pain. Mind you, you can have enough pain where you become depressed from it. And then we can go into pharmacotherapeutics that try to address both. But I try to first understand, all right, is this your only issue? Is there anything else? And I try to set the visit, the expectations for the visit. Like, this time is yours. I'm here to help you. And because some people they're angry, they're in pain. Sometimes they want to fight. And when people don't want to be vulnerable, they try to put up a shield often. And then it's hard to break through the sort of the American man ethos of you can't cry and you can't show weakness. And I try to say, I'm here to help you. And I try to often convey, I know you don't want to be here, but let me help you to get well. So try to share as much as your history as possible. And I also try to connect with them either by asking about their day or something else about their family, or if they're there with a family member, so that we can try to get this rapport built up so they're more likely to share and become a little more vulnerable. But sometimes, in the ED, I have a little bit more time. At some direct primary care practices, they have a little bit more time. Right. But sometimes you have 15, 20 minutes. And if you're really trying to reach to that person, I just try to say, I'm here for you. I may inject a little humor to get them to let their guard down a bit. And then I try to say, what else is really bothering you? What really brings you in today?
Hmm.
That's huge. And Dr. Baiden, I know you're going to say something as well. And another example I was thinking of right now is if I am vulnerable with my partner, if I'm vulnerable with a friend, right? And I'm trying to be open, emotionally open. And like Mook said, they use it against me in an argument or something like that later down the line. Like, how do you even mend that mentally for yourself? Is there something that you just have to be strong and be like, hey, you know what? I'm going to continue to be open and have this dialogue. Is there something that you can even help listeners start that process?
I think in the beginning, as a provider at least, I think it's important that the provider also has done some inner work in order to relate to other people. Because I think once you've done inner work, that energy just kind of exudes and people can feel that and gain a sense of maybe safety enough to share. And I think in my practice, I've been fortunate to develop a relationship with people enough so that they can share. Now, personally, when you're talking about your friendships, I think it's important to realize that the people that you have in your life, you can cultivate those relationships. And so if the people in your life don't love you at your worst, then there's something in that you need to reevaluate. What we're trying to do when it comes to healing, when it comes to vulnerability, is to also love yourself at your worst, not just at your best. It's loving your whole self. And that's the kind of relationships you want to foster. I mean, some of you are married or about to be married, right? And think about your partner. There are things, I'm sure in an argument that you might throw some shade. But at the end of the day, when that bond, when that love is real, they still have your back. And that's the kind of relationship you want to cultivate. And so maybe it's more about reevaluating, if this person cannot see me when I'm at my worst and still love me or still appreciate me or still value me, then why is this person really in my life? And then also realize that it's not about you. It's about the love that they have for themselves. And so they're projecting that negativity back onto you. And so that's the other part of it, is to kind of take a step back and realize it's not you. Yes, they were mean. They were terrible. They were horrible. They threw that back in your face. That's a reflection of what they feel about themselves.
Interesting. So as I think about what you're saying, especially the way that you see love and seeking that love, I mean, do you see particularly when it comes to vulnerability, do you see a difference in demographics of the people that you see? I mean, obviously, male and female are going to be one thing in itself, but what about, ethnicity? Do you see the clear differences in that? Because I only think from what it is to be a Black man, and like, if you're looking for the world to show me love, I'm not going to get it. I'm not going to get that in a lot of places. So, again, let me stop. Do you see differences?
Daren, do you want to take this?
Yeah,
Okay.
gentlemen, I'm trying to process I'm trying to see I'm trying to get to the heart of the original question was that you're asking to begin with. I was a little lost in that and trying to find out, we have a medicalized version of vulnerability, or at least to try to explain that, sort of juxtaposed to an inner experience. And then nestled somewhere in there needs to be the root of the problem, which of course is, you're talking about white supremacy. We talked about that last time. So at least for Black men, at least, and for Black women as well, or any Black person that walks this earth, white supremacy is at the heart of it. And part of that is to convince Black men that they're less than, right? And that, of course, informs the whole spectrum of how we identify ourselves. Doc mentioned it earlier when he talked about. By the way, Doc, thank you for your service, my brother. I'm Army as well.
Thank you for your service.
So, I was glad to hear what I heard. What you had to say. Praise God. Y'all don't even know how important this is. This brother right here, and we have so few Black officers in the military who are line officers, that have his experience, Doc's experience. It's rare, so I'm gonna tell you that right now. So the Army was kicking brothers out not too long ago, and in droves.
Wow.
So congratulations, my brother, for all you've done and all you continue to do.
Absolutely.
Thank you too for your service.
So welcome. So that's the way I'm looking at it. So you guys know I'm always at the root of the heart of the matter, and so we have to. And Dr. Baiden's beautiful, rather than outward facing these issues, turning them inward, right? The inner experience and what that's about, and how that shapes us, and how it creates this cycle, this vicious cycle that we've all inherited from, unfortunately, where we live and the circumstances of our birth and so on. So it's more than just, I think, taking medication or being evaluated. I think it's something much deeper than that before you even get to that point. If people are otherwise normal and have neurotypical, behaviors and so on and so forth.
Most definitely. Now, that makes complete sense, because obviously the question is important, because we have different people that come from different backgrounds. It could be internal, where they need to make sure that they look inside and be like, hey, it's not just me, and it's maybe the people around me. It's also just making sure that you can be vulnerable with your provider or someone to get your feelings out there. So once a patient or someone has gotten to the point where they are comfortable and open enough to sit down and talk to you, and again, the most important thing that you guys both said is that you try to make a connection. You know what I mean? When you talk about mental health, is not just about drugs and things like that. It's about creating a bond. And that's what a lot of people don't think about. I'm going to a doctor, I'm getting some medication, hopefully I feel good. Most of the time, you need to sit down and talk to somebody so they understand you, and then we know where we're going from there. Because sometimes you may not even need medication, but we need to find out what the heck is going on. And I love that you guys said that. And that kind of goes into my next question, is like, once you've created a bond and you figure out that there may be an underlying issue, what is the next step from there? Are there symptoms that someone could be looking out for themselves? Let's talk about depression. That's something that is prevalent in Black men. What is something that they can be looking out for to see, like, hey, maybe I do need to come and ask for help because I think I am depressed?
Anybody? I'll take that. If nobody, y'all can certainly chime in. So in my practice, I'm seeing more men than I have before. So I'm actually a PA, if you didn't know that from the last episode.
Mm-hmm.
I work in psychiatry. So I see a lot more men than I have been before, which is a good thing because men generally don't come to seek care, and are very, very underrepresented in psychiatry. Although the pandemic has certainly changed a lot of that, we're seeing more. I'm sure primary care can probably add to this as well. But so men, we've been conditioned not to see, to not to even look at our. It's taboo to even go there, and you'll see that within certain cultures, right? In certain cultures, it might be. Uh, Boy, just pray it away. Go ahead and just pray it away to get what you got to get at. And then other cultures will be like, it's the devil. You ain't going to church enough. And it's mysticism associated with the male. The male. Whatever we want to call the male identity. Which is contrived to begin with, in my opinion. And so, y'all, I think. We talked about this last week. We mentioned this in terms of the notion of trust, and that men tend to get more if men want to be healthy, right? They have a better chance of being healthy if they go see a woman in primary care, because women in primary care tend to follow the guidelines, right? They're sticklers to the guideline, whereas men are like more cavalier about it. Let's try some different things, add some salt and pepper in here, shake it up a little bit. And, and that might not necessarily be, the best care for the patient. But in my field, I see it. Don't see as many men as I see women, but I'm seeing more men. And when I see them, I praise God, because generally I don't see men. And that come in to the clinic.
That's huge in itself, is that men are actually open enough to come in there to talk and ask for help. So again, I even asked you, Dr. Baiden, if I'm coming to you now, I feel like there may be something. What could you tell our listeners of maybe some warning signs that they could be looking out for?
So in my practice, whoever walks through my door, I'm screening everybody, regardless of what you're coming in for. So that's how I roll, because I just feel you can't have complete health without assessing mental health. So when you walk in my door for the first time, or if it's the first time of the year, you're getting an assessment. There's two different assessments. One is called a PHQ-9 that looks for symptoms of depression, and then another one is called a GAD-7, which looks for symptoms of anxiety. And that's just at a baseline. I even do it in kids from 11 on up. So that's just my MO right there. But
and real quick, not to cut you off, but express the importance of the PHQ-9. I don't think we're getting that enough out there, is because we come in there and we assess patients, or I don't, but the patients are getting assessed, and maybe they're not getting this paper to help identify maybe something that's actually wrong. So again, just what are some of those criteria for listeners? They're like, hey, I know you screen them, but what does that mean?
Yeah, so it's a questionnaire, it's a self-assessment. And I think it's beautiful because it provides both subjective and objective measures to suggest that maybe somebody may have mild, moderate, or severe depression. And just because you answer a certain way doesn't mean you're automatically going to get a medication that day, but it's just a good baseline of where you are for that day. And it can be very situational. I mean, you could have had somebody pass away recently. You could have had a breakup. And so your scores may be different at different times of the year, and that is okay. But just the fact that it gets a person thinking about, oh, yeah, I have been feeling tired lately. I have been eating more, sleeping more. I have been angry or irritable. Those are some of the questions. And then you're putting words into the feelings and emotions that they probably couldn't process to you otherwise. And so that's another way that helps me know that there's a little bit more going on.
I love it. And I'm coming to you, Dr. Ferguson, because we talked about this a little bit off air, and the importance that depression doesn't mean that everyone has the same cookie cutter depression. Like Dr. Baiden said, there's mild, there's moderate, there's severe. So express a little bit from your background on maybe patients don't always need medication, like Dr. Baiden said, based off of their type of depression.
Yeah, so As we were talking about earlier, I had to take care of quite a few young enlisted soldiers that were in early signs of stress disorders and often anxiety provoked due to this constant either visualizing trauma, often in the Middle East or sometimes on their own base. And it's just, and then they start to kind of have this almost like a battle fatigue or stress. This is all like precursor to being formally diagnosed with PTSD. But I noticed that many of the, I don't want to call them quite lazy. I'm sure in some regard they might have been following a guideline that might have been much older, but they were very quick to put a lot of my soldiers, or they eventually were soldiers under my care, but they would come in and they would say that I don't even know if they might have done the PHQ-2 or the 9 for them. But all I know is many of these guys were placed on SSRIs, SNRIs, and they were never placed or had it commingled with counseling opportunities. They said they felt that putting them on the pill and then putting them back into service. And the thing is, that's not how, as we as clinicians, particularly physicians, are trained. Now, some of us don't always follow due to sometimes the rigors and constraints and time to provide with the patient, but you got to make time. Because then you're not providing optimal care. So as I was dividing it up and discussing earlier, many mild to moderate, you do a trial of therapy first, and we do that based on that scaling score, sometimes to give us a little bit of a hint of how much where we would start. So that PHQ-9, I think it's like 0 to 27. Correct me if I'm wrong, Erica. And the thing is, many of the depression that I see or that I've seen that's been presented, especially back in my military time, they were mild to moderate. And so many of these guys, I would have said, hey, let's get you into counseling. Let's get you a peer support group. Let me get you a battle buddy that you can rely on. Let's do that for the next 45 to 60 days. Now, if he was more of a threat or risk to himself, then I'm like, all right, this is more crisis. Let's get you out of the crisis period first. And then we can take time to treat your depression or your anxiety. And so I would always push and offer counseling because it's so readily available and paid for by the Army. And it's readily available in almost many, I would say, more, if you have more than 1,000 or 2,000 employees, you have EAP, Employee Assistance Program. And they will give you, as long as you're a full-time employed or better than a 0.75 FTE, you can go see a counselor. But someone's got to tell you about that benefit. Someone's got to suggest it. So if you're going to your primary care and they never mention it, and they're just going to put you on this pill that's going to give you all these side effects, and they may not even discuss it with you. And that's often what I had to deal with. I had young soldiers, often brothers, placed on SSRIs. They're getting nauseous. They're getting anxious. They didn't know that they had to taper up. They didn't understand some of the directions well. And that's how some people get lost to follow up. Then they feel worse because they just come off. They don't get refilled. They never got counseling as well. So you just did almost, in a way, harm. What makes you think they're going to trust you to go seek and trust this healthcare system again?
Crazy.
So that's why I often say,
huge.
And if you're moderate to severe, and that's when I go, when's the last time you did something that was fun? How many times a week do you play with your kids? Do you enjoy your job? And if they start answering no to a lot of that, or no, or not at all, then I'm like, let's try 30 days, come back and see me, here's an appointment. We can consider this pill, but I'm gonna start real low and I'm gonna go slow. Because ramping up
always has side effects.
So anyhow, I hope I answered the question there, but my point was I pushed counseling a therapist first. And then if there's moderate to severe, I'm like, you got to have it at the same time, because we know severe depression, people do better with pills, but they still need therapy, like all 3 tiers do.
And
so, mine. I got a quick question. It'll be maybe a 2-minute answer, but I feel like once you move over to therapy, there's therapies that work and therapies that don't. I mean, one-on-one sessions don't always work with everybody. You always also mention peer groups. So how do you go through that trial? Because getting them to that point, is one thing, but then what do you walk through? How do you get to figure out what works for who when it comes to therapy?
One, I asked them, have you done it before? Some of these books that I've seen, they're like, hey, I didn't like my last therapist. And that's when I immediately will suggest, and these are often veterans, active duty, but there's these group support sessions at almost every Wasatch Behavioral Health, Davis Behavioral Health. Many of them have these group sessions where they meet once a week, and you're with other people with similar disorders, and you have a moderator, a therapist that's there with you. So you're not alone, because it's a struggle when you feel like you have no one, or you're the only one experiencing this, and you're not. And it's a little bit different for everyone, but if you have a safe space, then I feel that it's therapeutic as well, and then you got time to allow the meds to work, because it's not fast. That's what a lot of people need to understand. It takes weeks, and then you got to see if you get on the right dose.
Yeah. So it's important that you say that. Jojo, do you have something?
No, I just wanted to know, in you guys' practice, do you guys see Black males being pushed to meds faster, to therapy faster, to getting kind of thrown to the side? I know obviously you guys aren't doing it in your own, but like in the medical field, what do you guys see?
I think you always hope that the clinician or the provider that is seeing a person is treating them as an individual and seeing where that person is at that time, and doing what's best for that one person, and not generalizing a population. But we all know that that's not necessarily true. It's also important to realize that in 2013, there was a fifth revision of the DSM, that diagnostic manual that gives us criteria how to diagnose people, but it wasn't representative of primary care physicians' input. And primary care physicians actually provide 87% of mental health care out there. So when you look at the revision from the DSM-5 in 2013, it actually was not very scientific, and it provided criteria where it wasn't very robust in saying that this equals this. And so we found that there was an overutilization of diagnoses and people being put on medications for many just life stressors. So, and then people being overdiagnosed with attention deficit, or people, especially like adolescent young Black men, being diagnosed with behavioral concerns when it wasn't really a behavioral concern, and then putting on other medications. So it's, I don't even know if I'm answering your question well, but it's a very tricky process. So
it's a lot of data that's not there, right?
Yes.
You're not. Yeah, it's a lot. That's crazy.
Yeah, that's a trip, because like I said before, I'm a pharmaceutical rep and I deal with bipolar disorder, and I have to talk to clinicians mainly about how to diagnose a bipolar patient, when you would think that's a psychiatry job. But like you said, your MDs, they're getting all of it. The family practice, they're getting it all. So I think it's really important to have these conversations and understand that it can't just be about the medication part. It has to be just educating yourself and looking at these symptoms, because counseling, and I'll use myself as example, I didn't ever try counseling until I found out that my job provided it. And again, then I didn't know that until my mother passed away. And then my manager was like, oh, we have counseling. It was like, why did it have to be something so severe where you see I'm affected now that I need counseling, rather than just that being the norm of, hey, here's your benefits for your job. You know what I mean? And I had no idea I had that. Free, didn't have to pay anything. I had counseling for myself. I had marriage counseling. I had children. I had everything, and had no idea. So
most people don't know what it means. So like if they say, oh, there's your list of benefits, EAP, what is that? Employee assisted program. We're like, oh, that means I get free tickets, or I get like a crutch?
Yeah.
Employee assistant, like it's not explained well. So that's why many people wouldn't even think about it. But it's something that's underutilized, that's paid, that your job will pay for. Highly underutilized.
And then also letting people know that EAP program is usually off campus. So don't fear that somebody from your office is going to see you going. It's pretty confidential.
Yeah.
All right.
And that's what we talk about, like the distrust is, you don't want people to know that you're going to counseling, and you don't know if someone's going to talk bad to you, your manager, or whatever the case may be, if you perceive that being weak. So again, I think having this open dialogue to know that that should be the norm before you get on pills and go these other different routes. So even moving on, just talking about the distrust part, where do you think that comes from? I know we talked about it a little bit last time, but how do we get past that as Black men to hopefully have trust in the system? Like, hey, if we come educated and we come open and honest, is there a way that we can be a little bit more open to having that trust with our providers?
It's so hard because there's just so little representation, you know? And I think that's half the battle, is just finding, I mean, even going to therapy and thinking about the therapist sitting across from you, you know, looking at that person, you're like, how are you going to understand where I'm coming from?
Yeah.
Why am I going to spend all this time explaining to you where I'm coming from and how I got here, when if I went to somebody else, they would already know. So,
No, go ahead. I'm sorry.
No, please.
I was going to say, do you think it's important to get people that look like us? Is that what we need to reach out for to get us more comfortable?
It's a good start, because you're more likely to have someone that's going to have less bias and are going to be culturally competent. So that's one way. That's one way to start. If you can't, maybe look for reviews of someone where they.
I'm telling y'all, those reviews are heavy. When I tell you, I was looking for months before I I called my doctor. But I'm looking at reviews. I'm looking at every website. I'm jumping on everything. I'm like, I'm not playing around with it, but I gotta find somebody that looks like me, because I've had other doctors in the past, and I spoke to Walt about it, Mook, where I've been diagnosed with things. I'm like, I don't know if that's true. I finally find a doctor that looks like me. To go even deeper, it was a kidney. My kidneys function at a high level. I go to another doctor, and they're like, well, most Black men's kidneys do function at a high level. That's normal. And I'm just like, wait, so I'm getting muscle biopsies and I'm getting all these different things, and then come to find out my kidney function is normal for me. So I think for me, it was super important to find somebody that looked like me and kind of understood, like you said, the cultural differences when it comes to, going to see a doctor.
What would be your recommendation on how frequently you visit, somebody to talk to our psychiatrist? Is it something that you just set up when you are in a situation where you need to talk to somebody, or is it healthy to have somebody that you're just regularly talking to without there being a problem or present?
I think there's always a benefit. Oh, sorry, go on.
Just to make sure that there's an explanation. So psychiatrists don't always provide counseling, but they do prescribe medications. And then psychologists or a social worker or a therapist usually provide the counseling. And so it just depends on what route you're looking for. And so I would say it's probably more important to have a therapist, social worker, counselor, and a primary care. But that's my bias.
Okay. and sorry, go ahead. It sounds like you're going to explain the benefits of that.
And for frequency, I tell everybody, if you can get in, I said, even if you think you have a healthy relationship with your family, your significant other, I've only seen benefits from counseling. And so I tell everybody, don't you know that if you can go to a third party and discuss some things that you've been thinking about or troubling, and you go in, even if you just debrief with them and and maybe they're just actively listening and like you've been heard, and you left not feeling judged. And if they did pick up something, they can give you suggestions. It's almost like kind of like, in a way, almost having a coach, but for your mental health. Absolutely. Why would you not want to check in for that with that person? So I made a point, being a disabled veteran, that I have a therapist. And did it start when I, got really, really sad and depressed after a breakup. And I went to someone over here at the VA Salt Lake, and they took care of me. And so sometimes it starts with a triggering event. But if I can convey to anybody, don't wait for that. Take care of yourself now. Treat your mental health just like you would treat your body. Don't wait until, because it's an organ too, right? And so you don't want to wait till it's impaired until you treat it. So, and Eric and I have to battle this all the time. A lot of people care a lot about their eyes. So they're going to do exactly what they say for their eye doctor. But they don't often sometimes listen to their family medicine physician when they say, hey, if you don't control your blood pressure, in 8 years or 10 years, you're probably going to have a stroke, and then you're not going to be able to work anymore. And people are like,
That's the silent killer.
Doesn't seem tangible, but we're still trying to protect an organ.
Yeah.
And we're trying to address any dysfunction that might be occurring. Same with your brain, same with your mental health. So I tell everybody, don't wait, just get in, see if you have access, make sure you're insured. I think there's some free therapy that's offered by some counties, but it's based on need. But yeah, I encourage everybody. I mean, my significant other and I, my fiance, we got engaged about 5 weeks ago now.
Hey, congratulations! Don't try to just go over that real quick.
That was quick. He was gonna let us fly over.
And first thing I said is like, all right, well, we're gonna get some premarital counseling. Oh, why do we need that? We do. You're marrying me, so we do.
I think that's on a whole nother level, is doing the premarital counseling, because again, most people only do that when there's an issue. You know what I mean? And the biggest thing is, like, you did that because you've had counseling and you understand the benefit. I found so many people that have tried counseling because maybe something happened or something, they were sad. And then once they've got through that, they stayed with counseling. That's people do that. You know what I mean? That's not just like one person or two people. Like, once you realize how beneficial that could be, like, you want that around. I told my grandma one time, this is personal, but I told my grandma, I was like, you know what? I think I'm gonna go to do some counseling and talk. And my grandma was like, no, don't do that. Come talk to me. We'll sit down and have a conversation and I can help you. And I felt like in that moment, I was like, see, this is why people don't go get counseling or ask for help, because they'll go talk to grandma. You know what I mean? And we have to be the change a little bit and be like, okay, it's cool to go to counseling because they're going to know a lot more than me or my grandma. You know what I mean? So I think it's important.
Premarital counseling is clutch.
That's dope. That's super dope.
And to speak about someone deterring, so my family was my dad. He passed away about 7 years ago now, and he said when I considered counseling in the past, he says, "Don't do that. Your job will find out." So that's how my dad was. He was worried about me being able to maintain employment. They'll find out your record, which is also another reason why sometimes active duty soldiers will not volunteer, because they're worried about being ejected from their army.
Interesting.
They may not have the skills to set up to immediately go into a job. And when we know the unemployment rate's higher for veterans, so they will not want something in their record until maybe at the very end, which means they didn't get treated while in. But the system, because commanders have some leeway, and sometimes things aren't as protected as they should be when someone that's non-medical can maybe know about your medical history, and you just hope they're fair and they don't use that against you. I've seen that happen. They'll be like, "Oh, that's the crazy soldier over there. He's on all those business."
I see it the same. I have some officers in my practice, and it's a fine line between what they want to share or what they want in their record for the similar reason. Reasons.
How do they have how is there no protection from that?
Say again.
I said, how is there no protection from that?
It's about the enforcement of it. So it's like many things in the military. They write many a law, but if it's an old boys club and no one wants to enforce it, and it's fight first, think about a soldier's health later, that sometimes occurs. And so they're not always putting the soldier first. I'll put it that way.
Right.
So you're probably making a lot of enemies. I mean, especially thinking about you being in the Army, you're in the belly of the beast, right? Where you are in a profession where you are not supposed to talk about mentality and your mental well-being at all. And you're on the other side of this, where you're trying to attack that and open that up for these individuals. So I can only imagine the position that you were. Well, maybe not. Maybe they're open to having them talk to you. But do you find yourself being in conflicting situations, I guess, when you were back in the Army?
I would say I was a mid-grade officer, so rank helps. If you're the only doc amongst a bunch of non-docs, then that kind of degree in the training, I'm like, no, I know better. This is my place. You're going to do as I recommend. So that's sometimes the only thing that kind of saved me. And I had to tell somebody that outranked me, but it's a colonel, and I'm like, yeah, you're wrong here, sir. Respectfully. And not go all right, because I think in the net, because they understood that I may not play their game, and I'm like, I will document that you went against my wishes, and that's not going to be good for you if something bad happens to him.
Yeah.
Okay. So that's often how I said. I was like, I'm trying to help you.
Right.
Help me sustain the soldiers.
So we've come to a place where now we're open, we're honest, we're asked for help. We've maybe had counseling, and now you have a patient that maybe does need medication. What information should patients know before they go see a clinician about an SSRI? And please, Dr. Baiden, help me explain what an SSRI is, and yeah, just kind of the normal steps on maybe giving someone an antidepressant.
So again, looking at their presentation, looking at their scores from those questionnaires we talked about earlier, how much time has lapsed? Are they still having symptoms that are interfering with their day-to-day? And also knowing what the symptoms are troubling them the most, because depending on where they are, there's certain medications that might fit their profile a little bit better. There's some that have some overlap with both depression and anxiety. There's some that are better like boosters if people need a little bit of oomph. There's some that are better at helping people mellow. There's some that have fewer sexual side effects than others. And so just kind of getting to know where they are and what their needs are in that moment. And then letting them know and being honest and transparent that it's very much a trial and error process. Trial on their part and an error on our part to figure out what may or may not work best.
Got you.
And to follow on with that, I do go through their options, especially when we do get to meds. And I'll give a personal story. When I was diagnosed with adjustment disorder with depressive affect, I was offered bupropion. And so that's one of the medications that will tend to have less of a sexual side effect and actually sometimes can help libido, many people state. And it's more mild. And you can start low with it. But I found it hard to take pills, even though I tell people to do it all the time. I had to take it twice a day, and it was hard to take twice a day. And this is a doctor telling you that was hard, and I'm not impaired. And I know someone was telling me to take it, but you know what I decided? I said, you know what? I'm just going to go see my counselor more. Luckily, I had the ability and the time and the resource to do that. And then I got through my hump, and I said, you know what? I don't need these pills. But in the beginning, I did try to start taking them regularly. And but so what I do is I go through like, hey, these are your 4 options. And first I have to figure out, am I treating depression? Am I treating anxiety? Or is this a little bit of both?
Yeah.
And how's it function?
And oftentimes it's transdiagnostic. I think it's, again, the DSM just bothers me so much, but it's not fair to take a human being, a complex, beautiful human being, and lump them into one category. Oftentimes it's transdiagnostic. We don't fit neatly into one box or another. And so to say that I'm just going to address this part of you without addressing that part of you, I think it's kind of myopic in how the practice can be.
Yeah.
And that's a lot of times how you layer medications as well, rather than trying to treat the core symptom. You'll try to treat every issue, and then that's how a lot of times patients will have 4 or 5 medications, like an antidepressant, an anxiety medication, a sleep pill, when maybe it's counseling and just treating kind of the depression part could benefit all those other symptoms that they're getting. So I think that's a huge point. And compliancy, right, Dr. Ferguson? Like,
I could take 1 pill twice a day.
Right. I can imagine twice a day, but we might forget. You know,
right? It shows you right there. So, and Erica can attest to this. Once you start pushing people past 2 pills, you're lucky to get, what is it, like 30% sometimes compliance once you go past 2. So imagine if someone told to take 4 pills a day, they're probably taking half to a third of those.
Interesting.
Even though they'll say, yeah, I'm taking my meds, doc.
Yeah.
Like, are you?
Right.
So So what do you say to the person that's scared of getting hooked? They're open to trying it, but they're scared of being reliant.
I guess I'd have to understand what hooked means. You mean
So
like dependent?
Luke, you bring up a good point, because most of these
just the paradigm.
medications, they're supposed to only be for 3 to 6 months. We're only supposed to be prescribing these medications for 3 to 6 months.
Not life.
And so I think what you're saying, Luke, is, people who maybe want to take it for the rest of their lives because they like that feeling that they're getting, that suppression, that numbing, right? Is that what you mean? Is that what
Yeah, maybe they feel like this is what gets me out of this slump.
Right.
I need this forever.
This is my new normal, and I don't want to mess with it. Yeah.
Right.
We do see that a lot. And I think it's, again, like Dr. Ferguson mentioned, being as transparent as possible, letting them know these are supposed to be a temporary course of action. A 3 to 6 month period, we'll reevaluate. We'll try to get you tapered down as much as possible to the lowest effective dose. Is therapy working for you? Maybe we try a different therapist for you, or we go a different route, because if this is something that you need for the rest of your life, then we are not really addressing the core issues, the core concerns. We're just palliating them or numbing them.
Yeah, 3 to 6 months. I didn't know it was just 3 to 6 months. I know of many people that take it, been taking it for years.
Me too.
And that's what
I didn't know that.
They should be trying to transition them off. So if anyone any of your listeners, go in, and this is where it helps to have an advocate. This is where I go back again. It's okay to question. And I think there's a fear of I don't want to get back to where I was 5 years ago when I was really in a dark place. That's my fear. That's why I don't want to get off it. Or I tried to get off it before and I felt awful, because the tapering, you get these symptoms of nausea, vomiting. You feel like electric shocks are going across your skin. You get headaches. You get sweats. This is just with the taper. So then that person just needs to be on a slower taper. But it's like, if your mind's right, though, and you were on something for 10 years, that's going to be a slow taper. I mean, we're looking at 4, maybe 5 month taper. Instead of someone, if they're on it 3 to 6 months, you can get them off it in about 30 days. And so that's the concern. And that's the fear. People don't want to feel sick, and you will feel sick. You'll feel like you have, COVID, the OG strain.
Can't taste or smell nothing.
You might feel that way. That would be the Wuhan one I'm referring to.
Right.
I think it's 0157. Anyway, but that's my point. So there's an aversion, and so I don't know if I necessarily see it as dependency as opposed to a fear of what's going to happen. What's the alternative is I'll feel like crap, and then I got to go back on it again.
Right.
And so, and then there's some folks where their symptoms are so chronic they need it to function and they can't get off. But that's actually the minority. And so SSRI, so selective serotonin reuptake inhibitors, and then SNRIs. SNRIs are not as effective in treating depression and anxiety. They're kind of a little bit better for depression and if you have a comorbidity of pain. That's how they're a little bit better. But when it just comes to treating a straight disorder, SSRIs are more well studied, less side effects. But they're highly prescribed here in Utah. Some of it's part of the cultural effects and pressure, particularly in women here. And so it's prescribed a lot, and it's often a go-to, and it's part of the culture here. I remember when I arrived here in 2010, there were many jokes about how it's in the Provo River, no law flowing through there.
Oh man,
that are prescribed that in Utah County, and in Salt Lake County as well. And you would think, wow, these people seem pretty happy, but everybody's on it. And I don't know if they are often being given or mentioning you can stop counseling. Regularly or every 2 months could be a great and cheaper alternative, because you never want to go on some trip and then you run out or you didn't get your refill, and then you're miserable as you're having acute withdrawal off this medication. So it's either fear of withdrawal or fear that I don't go back to my dark place where I didn't have my emotions or control before.
Got you. No, that makes complete sense. And I've seen people where because they're feeling better, they'll stop an SSRI cold turkey, and sometimes they have bad effects there. So the listeners, make sure that you're paying attention to the titration is huge on making sure that you're staying compliant and staying stable.
Yeah.
Now, in the mental health as well, because I'm telling doctors to use my medication all the time, I also have providers that have patients that don't want to use pills at all. You know what I mean? So what are some of the other options, maybe a natural resource or spiritual resource that people can do to help with their anxiety and depression if they don't want to take medication from a doctor?
There's lots of different options and things that are in the woodworks. Let me just give you a statistic too. There's been overestimation on efficacy on some of these medications that are traditionally prescribed by pharmaceutical companies. So there's been some head-to-head data between like placebo versus their medications, especially in mild to moderate symptoms, where there's not that much of a difference, but the pharmaceutical company may not divulge that information or publish that information. So I think it's up to us as clinicians to do a better job at giving people time and other resources. So when we talk about other ways to treat depression, anxiety, and other mental health concerns, there are what we call plant medicines that are available. There are things that are currently in phase 2 and 3 trials with the FDA, things that are going to be possibly rescheduled or reclassified to provide some benefits. Some of these medications that are coming up, again, that are going to be reclassified have shown remission rates after maybe 1 or 2 doses that have lasted 6 to 12 months. And so that's going to be huge and an incredible game changer for the pharmaceutical industry, who has people on these medications day after day after day.
Again, what does remission mean?
Thank you. Yes. So remission means symptom-free time, or maybe even you don't meet criteria for that diagnosis anymore.
Yeah. And that's huge to have something that's effective that fast, because like you guys have said, normally it takes weeks on end to have some type of remission-based efficacy. So that's huge to even hear that there's different medications that are coming out.
But even these medications too, it's not the medication itself, it's in conjunction with psychotherapy. So it's this medicine assisted psychotherapy, that medicine assisted psychotherapy. And so it's hard to know if it's just the medicine itself or the psychotherapy itself or the combination thereof, but it seems to be that combination thereof that's producing these benefits. And plus it's giving people like 40 hours of intensive therapy and specific therapy that they may have not had access to. So it's pretty remarkable if we could have everyone undergo this kind of therapy with medicine, what kind of outcomes we could have.
What is psychotherapy?
Going to a therapist or a counselor. There's different types of psychotherapy. There's cognitive behavioral therapy. There's internal family systems. There's ACT. There's all different levels of therapy that may have a better treatment approach to certain ailments than others. So like if somebody's significantly anxious, CBT or cognitive behavioral therapy may be a better form of treatment. There's things called EMDR, which I'm sure some of you have heard of when it comes to like PTSD treatment and helping replace memories in different parts of the brain so that they're better processed. So there's lots of amazing things in the woodworks. And then these newer medicines, again, that are going to be reclassified hopefully soon, have also shown tremendous efficacy when it comes to addiction. So alcohol use disorders and opiate abuse and withdrawal. So it's pretty exciting.
And they said we're in an opioid epidemic, right?
We are. And, some of these medicines that are going to be reclassified hopefully soon have been in use for thousands of years by indigenous people. By our people, there's something called ibogaine that is used in Western and South Africa. And that has been right now in like phase 2 trials showing such tremendous efficacy with opiate abuse and withdrawal.
Ibogaine, what is that? If you give us a little background.
It's hard. It's a plant medicine, but we don't quite yet know what it is and how it works. We know of like other things like ayahuasca that works with certain neurotransmitters, specifically like, your serotonin. It works with a little bit of dopamine. It works with a couple different things that we traditionally know with our SSRI medications. But these have been around for thousands of years, and we have receptors in our brain specific to these plants. Animals have receptors in their brains specific to these plants. So it's pretty cool to think like, oh, these are of the earth, these are here, they've been in use, but for whatever reason they were classified as being more harmful or being easily abused and having no medical benefit. But we're now seeing resurgence.
So and that's what I was going to go back to, is when you said reclassified, I want to make sure that people understand what that means, is that they've classified it as something, but now they're going back to do more studies because they've seen benefits, and then they're going to, okay. I just want to make sure I was following.
So similar to like cannabis, right? So federally at this time, cannabis is illegal, but in certain states, they have made it legal because they're seeing such tremendous medical benefits for some people in some cases, like PTSD, with cachexia, which means like severe appetite suppression and subsequent weight loss. So it helps people gain their appetite back, helps with nausea. We use it for patients who are undergoing chemotherapy. We're using it for certain seizure disorders. So yeah.
No, it's huge, because a lot of people don't realize that a lot of pharmaceutical companies are using plant-based products. Obviously, they're putting a whole bunch of other things in there, but a lot of times there are plant-based products in there. So I think you just expressing that let people understand that you don't have to take pills or anything like that. There could be some plant-based options out there that can give you your serotonin and your dopamine effect on some of the issues that you have. And marijuana is one of them, as long as you're not using it, obviously, too much, or if it's affecting you and stuff like that. But marijuana is helpful, and there's studies to prove that. It's not just people saying it now. You know what I mean? So I think that's what makes it even more important, is that you have to do our research and understand that there's other options out there as well, other than just pills. I always use this as a example, and I don't have any facts or data. It's probably out there, but my mother, she was on hospice at one time. And the hospice company said, hey, we've seen miracles happen with cannabis oil. Obviously, you can't promote that and things like that. But I know from my own experience, when we did give my mother even just cannabis, it helped give her even more insight. Obviously, she still passed, but just having that little bit of life based off of a medication that is banned and is thought to have no therapeutic efficacy made me a believer personally, not just hearing someone say that. So that stuff like that means a lot. It makes me want to pay attention to other plant-based options out there. So thank you for bringing that up.
And we also need to make sure that our people are being included in those research trials, because we also have to understand, how does this work in us in today's world? And if these are so remarkable with such incredible remission rates, why aren't these things being offered to people like us?
Right. That is the magical question. But yeah,
that's a whole nother episode.
I don't know. I think we may have lost him.
Should I have been more inclusive? Yeah, I miss Daren.
Hopefully he gets back on.
You now just noticing he wasn't there, Richard.
He's been gone for a minute.
He's been gone for a minute.
At least 15, 20.
Things come up, but hey, we appreciate you guys coming on the episode once again on King's Hour. And again, is there any last remarks that you would like to leave us with, Dr. Ferguson? I know you have a couple of events that are coming up, so please let our listeners know where they can reach you and hear from you a little bit more.
Yeah, so Black Physicians of Utah, we are trying to do as much as we can to empower the Black community, educate the Black community, but also be a resource. So we have a YouTube channel, so if you just type in Black Physicians of Utah, subscribe to our channel. Also, you can, we have a live event coming up with Dr. Baiden and I, so if you like the knowledge we were dropping on, from her part 1, and me joining her for part 2. We'll be talking about patient empowerment and patient advocacy at 6:30 p.m. Mountain Time on IG Live, and that's at Black_of_physicians_physician. Type in Black Physicians of Utah in the IG, and it'll come up.
It'll come up.
Check us out. And
when did you say that is?
It's Thursday at 6:30 p.m. Mountain.
Got you.
So we'll be there, and with several other physicians and a brother from the VA. But just also go to bpou.org and follow us. We post a lot of our events there. We'll be at several health fairs in Utah. But we're here to educate Black community nationally. So if people like what's coming up, well, May 31st, we've got COVID and the economy, and we're going to be presenting there what has been the impact to us in the Black community as a result of COVID, because many of us were frontline workers. We're the ones that didn't have the option to stop working and stay at home and be remote. And I'm going to discuss what that impact has been and what's our way forward. So, and I do that with one of my mentees. So that'll be May 31st, probably at 6 p.m.
Excellent. We will make sure that we post all those. We want to be an advocate as well, because we want to learn as much as we can, and hopefully enlighten and incite others as well. So I appreciate that. We will be joining that most definitely. And Dr. Baiden, anything you want to leave us with?
Thank you all for this opportunity. It's been such a great, it's just been so great to work with all of you and to learn from you as well. So just make sure you listeners tune into King's Hour every week. Go back and re-listen to some episodes. These guys are doing some good work.
Yes.
The pleasure's ours. The pleasure is definitely ours.
We appreciate it.
Well, again, for our listeners, make sure that you like, listen, and share. You can follow us on all podcast platforms at King's Hour. And like I said, you can always look and find us on YouTube as well on King's Hour. And like we always say, make sure you be kings today and every day. Peace.
Black King.